Good afternoon, Chairman sir and friends. I'll just try to initiate the talk. Is on? Audible? Hello? Good afternoon, Chairman sir and friends. I'll just try to initiate the talks leading to this symposium on pylon fractures. Pylon or tibial platform fractures, these are complex injuries involving articular surface due to high energy trauma. These articular surfaces and metaphyseal comminution is there. There is joint infection, proximal displacement of the talus leading to severe associated soft tissue injuries. And above that, there is also associated fracture of the fibula. So these have been variously classified by Rudy, Algor, and IOACON classification is commonly accepted. There is increased severity of trauma and has implications in management and prognosis. So treatment, the optimal treatment of metaphyseal injuries of the distal tibia without major disruption of the ankle joint has not been well defined as yet. So surgical options are many, maybe conservative, conventional plating, intramedullary nailing, external fixations, MIPO, and combinations depending on situations. So classic open reduction and internal fixation requires extensive soft tissue dissection and periosteal stripping with high rates of complications. The infection rates has gone up to almost 30%. It's unacceptable. External fixation may result in inaccurate reduction, malunion, non-union, and pin track infections. These are associated with a high incidence of complications. Pin infection and loosening may be even up to 50%, malunion rates up to 45%. So result is usually unacceptable. Sometimes in stage 1, type 1 fractures, we may go for a intramedullary nailing of the distal tibia. The stability of fixation is very important here. There is risk of secondary displacement of the fracture on insertion of the nail, breakage of nails and locking screws, and final alignment of tibia may be difficult. Then MIPO, this has almost revolutionized the treatment, but sometimes there may be a non-anatomical reduction also. So most important in case of compound fractures or management of this type of injuries depends on patients. Timing is critical because soft tissue is the thing that decides whether you should go for surgery or not. So in this type of cases, we may go for a staged protocol. That is, first stage we do X-piece and fibula fixation and wait, and once the swelling subsides or the wound heals, as a secondary procedure, we go for a definitive fixation. So this is a case of fixation of the fibula, and sometimes we find also neglected fractures after a pylon like this, which are not uncommon in our country, and they may also be difficult for further management. And compound fractures, they are also common because people get treatment by bone setters, come late, and don't take primary care. So functional outcomes is very often compromised. Even patients who receive optimal treatment has a guarded prognosis. Patients get better for up to 2.5 years. Ankle scores improve with time in some cases, but always there is increased arthritis with time. So outcomes, 50% patients, they don't return to work, significant impact on overall function, 35% substantial ankle stiffness, 29% persistence of ankle swelling, and 33% reported ongoing pain. So in a review of the different study, the results are not excellent in many of the series. It may vary up to 70% to 85%. So orthodox outcome, Rudy type 3 fractures, long-term results are excellent, but not in an Indian context of view, because in India people like to squat, which is not possible in these cases in orthodosis. So how to improve the results? So that is the aim of the symposium. I hope all the speakers who will be following me, they will try to enlighten us on these different aspects of these fractures. Thank you.
Thank you Mr. Patra for introducing the topic, and we'll ask our next speaker, Mr. Saha, to come to the podium to speak about the evaluation and decision making in pilon fracture.
Respected Chairperson and my dear friends, with the results what Dr. Mahapatra was talking about, we are going forward to evaluate what this fracture is and to plan clearly and how do we understand this fracture. Let's get through some basics. Everyone is clear about it, but just to rehearse yourself, it was derived from a French word meaning pestle, mortar and a pestle, by Destot in 1911. English derivative of this word was what is a ceiling, and there is the ceiling for you. So a pilon fracture is basically dealing with three zones: the metaphyseal zone, the fibula, and the articular segment. What is this fracture? It's a fracture of the distal tibia. Huge energy is needed for this, mostly intra-articular, and the prognosis depends upon the amount of articular damage. Look at the load what is shared by the two types of fractures. For an ankle fracture, the yield point is down there, and for a pilon fracture it's up there. So much of energy is needed for a pilon fracture. That means on an axial loading, which is very rapid, more energy is dissipated when the bone fragments. And where does this energy go? It goes to the soft tissues and causes secondary soft tissue damage. That is more significant for pilon fractures. Accounts for less than 10% of all lower limb fractures and is mostly in the younger population. So it's a quick loading, large energy is dissipated, significant combination and a significant soft tissue injury. Dr. Mahapatra was already talking about this algorithm classification. I would not go more into it. Type 1, 2, 3. AO specifically located the 4-3 segment. And look at the A1 and the C-type fractures. The A-type fractures are more of a rotational strain, a low energy injury. And a C-type fracture is more of an axial impaction. So you have the further classification 4-3, A, B, C, extra-articular, partial-articular, and complete articular. So if you fail to plan, then you are planning to fail. So plan what? Plan the initial management, my investigations, my timing of surgery, and what type of surgery I'm going to do. How do I reduce my fractures? How do I approach these fractures? And how do I bail out myself? Let's come from the history. From the mechanism of injury, whether it's a high energy or a low energy injury, it's an open or a closed injury, whether there is a neurological or visceral involvement as associated injuries. Most important, look at compartment. If you have a fracture of a pilon with an extension into the diaphysis, think about compartment. Any gross displacement of the talus should be reduced immediately when you see the patient in the ER. Look for comorbidities: smoking, peripheral vascular disease, diabetes, alcohol, malnutrition. Look at the soft tissue. It's an open or a closed injury. You have a clear blister there or a red blister there. Look at the swelling. We usually wait for a wrinkle sign. Align the bones as early as possible. We've already talked about the compartment. And don't forget, the age-old, well-padded slab helps you in a lot many cases. As we are talking about the soft tissue injury, it reminds us about this classification, Cherny and Goitzen. It has looked into all parts of soft tissue injuries, abrasions, cut, lacerations, but it's not looked into the most important, that is the swelling. That's the most important part when we look into a pilon fracture. Coming to the X-rays. Look at the X-rays. It should include the upper joint also. From the X-ray you can make out this was probably a low energy trauma. In this case it was a high energy trauma. But most important, from the X-ray you can see the tenting on the skin there. So alignment is so important and so immediate should be done. How do you align them? We will talk later in the course. CT scan is very critical. 3D representations help us to know more about the fracture lines and the articular status, which helps you to plan your implant and your approach. Talus repositioning makes sense. There you have the CT, which gives you a clear picture of the fracture lines, and that helps you to plan your fixation. So, to remind you again, always note the neurovascular status. Soft tissue is more important than the bone. Articular construction should be anatomical. Align the diaphysis, length and rotation of the diaphysis and the metaphysis. Cut as minimum as possible. This is the zone where you need to be like this with your soft tissue. So, 4 stages. Fix the fibula, tibial articular segment reconstruction, grafting is needed, if needed, and buttressing of the tibia. We talked about the staged protocol in the previous lecture, and various papers have come out, but today it's it's about 14 to 24 days, but today you're always looking at the wrinkle sign on the skin. That's probably the time when you can go ahead. So planning your first stage, look at the skin again. Don't touch your tibia before wrinkles do appear. In an axially stable fracture, you can manage with a POP slab, but most of the fractures are not stable. And putting them on a prolonged POP will shorten the soft tissue. So probably you need to do something. So, you might as well think of a fibular fixation with a joint spanning unilateral fixator or a biplanar fixator. While you are planning a unipolar fixator, the pin should be away from your incision, but never should be in the talar neck if you are planning for an anterior approach, any of the anterolateral or the anteromedial. The proximal, tibial, calcaneal and the cuneiform pins we are using to restore length, alignment and rotation. And also you can control the talar shift. The fixator doesn't really reduce the articular congruity. You should have radiolucent bars so that it doesn't obstruct your further radiographs. And slight over distraction is preferable, and the foot should be in neutral position. For a biplanar fixator, if the fibula is intact with severe shortening valgus angulation, you can opt for this, or if there is a delayed presentation, you can go with a transcalcaneal pin. Fibula is the key bone. See, if you fix the fibula, the fracture of the tibia also aligns to a great extent. So fibula is the key for reduction. Incision should be posterolateral. Use a stiffer contoured implant which maintains the length, alignment and the rotation. In a varus angulated fracture like this, so you do something with the fibula there. You probably will need to buttress it on this side with a medial combination and also do some articular segment reconstruction. There is the case for you. Planning your next step with the CT scan. You have your CT, you have your 3D recon views. You can identify 3 or 4 basic fragments, anterolateral, posterolateral, and the medial malleolar fragments. You can plan your approach accordingly. Anteromedial, anterolateral, posterolateral, along with the fibula, or the posteromedial, which is usually not required. But the usual sequence, oh, sorry then. So one important point, you should usually go from the posterolateral to the anterolateral reduction. There is a reduction, and the minimum space between 2 incisions should be 7 centimeters. You can also put in a femoral distractor and do a fibular plating, and also go in for the tibial definitive fixation. A low profile contoured stiff implant with the locking implants which are presently available in the market. Sorry, let the surgery start for the tibial articles. Thank you very much.
Thank you very much. Our next speaker is Dr. Bhaskar. here?
No.
Dr.
This must be
Bhaskar?
I was supposed to, I was invited to talk complete. Is he here?
No, sir.
Doctor is not here.
Next we Dr. Samarjeet.
No, Dr. M.M. Roy, I was supposed to talk to. Anyway, you can.
Good afternoon. I thank the organizing committee to give me an opportunity to stand here and talk in front of you all. Good afternoon, Chairman and colleagues. My topic is on compound pilon fractures. Thank you. Yeah. So briefly, I'll be touching on the various aspects of this presentation, where I'll start talking about some concepts, some controversies, the usual classifications, a case to let you know how we go ahead. Complications, one of my colleagues is going to talk elaborately on that, and to conclude my presentation. Now, as I start talking about some few concepts, now let's see, the plafond is sometimes confused with the tibial pilon, and these are two different entities. The supramalleolar portion of distal tibia is the pilon, and the other part is the plafond. Now these plafond fractures may or may not extend into the tibial pilon. Open wounds have been reported to be approximately about 20% of these cases. Now these are, as my previous speakers have already spoken, these are usually high energy compression trauma, and there is severe comminution into the articular surface, and obviously also the soft tissues. This is a pictorial representation of the position of the ankle at the time of impact, which determines where the predominant fractures of the tibial pilon goes as the fracture. Now open fracture, the definition all of us know. Now I would like to here not use the word compound, as it's a non-specific term in my presentation. Now this is something called an impending open fracture, and this is very typical with a pilon fracture. No? So this can also happen in a low injury trauma, where because of the tenting of these fracture fragments and the prolonged period of joint displacement or fracture displacement, if it is not reduced, can lead to pressure on the underlying skin, converting these closed fractures into maybe technically open fractures. Well, the principles of definitive fracture management as far as treatment of the pilon fractures are concerned, for probably the closed and open fractures should be essentially more or less the same, because the surgical decision making here predominantly lies on the soft tissues and soft tissues. Now the soft tissue problems produced by complex pilon fractures may be the main factor influencing outcome. Now fortunately for a compound fracture, the soft tissue injuries are evident to everybody, and we have to be more cautious about the closed ones where it's not very obvious. And of course, along with the soft tissue envelope, also diagnosing and treating the underlying cartilage lesions are as important as achieving their congruity as orthopedic surgeons. Compartment syndrome we should have a high index of suspicion even in a open fracture setting. And any wound in the fracture site or even in its vicinity in the limb segment should be technically considered as a compound one. Now here the assessment basically looking at the soft tissues to begin with, and we have to plan the timing of the surgery. And it is preferable to avoid the peak swelling time. So either you do a surgery immediately or wait up to 10 to 14 days until the edema in between times may lead to, otherwise the edema in between times may lead into wound problems. There are some controversies regarding the reduction methods, the type of fixations, whether to use bone grafts or bone substitutes, the type of plates, the size of the plates, and whether to go for stage, that is 2-stage or 3-stage conversions. Now, as we classify these wounds as the other compound fractures, so the grading systems have been the usual ones, the Costello-Anderson, the Chernes, the Baird and Spicer's, they help us. And the scoring systems focuses on the limb injury and the general health. Whereas the comprehensive systems, which combines both the systems, are probably more useful as far as treating the compound fractures are concerned, the AO system and the Ganga Hospital score. As far as the fracture classifications, it has already been discussed, the usual classification systems, all of us know that. Now, as far as compound fractures are concerned, the factors which influence this outcome can be local or the systemic ones. The local ones being the amount of the foreign body, the soft tissue devitalization and the bone devitalization, and systemic factors like the general health condition, medications, drug abuse. And factors that can modify open fractures are again contamination, whether it's the type of nature of contamination, the duration of the open wound until the person presents, the victim presents, the amount of energy involved in the injury, and whether there is a segmental bone loss, if or not the compartment syndrome is associated, if there is any evidence of any crush injury or any degloving injury. Here, the very important aspect is an internal degloving injury, which essentially might be looking as a closed fracture, but these are probably the impending open fractures. When we come to the treatment principles, we hear like any other fractures, more so when it's a periarticular fracture and especially when it's a compound fracture, it's better to span it and then to scan it, and then you plan your treatment. Treatment goals, the restoration of the soft tissue envelope, restoration of length and rotational alignment, the metaphyseal shell, bone grafting, and reattaching the epiphysis to the metaphysis and them to the diaphysis, restoration of the articular surface, and early mobilization. The options, as has been discussed, are many. It can be starting from a plaster immobilization to external fixators of various types or hybrid fixations, small wire external fixations, and open reduction and internal fixation. Well, the principles has been again elaborated by my previous speakers. Here are again protection to the soft tissue and staged fixations. Probably in the initial stage, you go for plating the fibula and an ankle spanning external fixator. In the interval period, we elevate the limb, we investigate it. Then in the second stage, we go for definitive fixation, and at times might go for primary arthrodesis of the ankle joint. So the key injury, the key issues here are injury and management of soft tissue is very key for the success and the failure. Now, touching few things about the general principles of open fracture treatment, debridement within 6 hours. The initial cultures are not of much value, whereas the cultures following debridement and subsequent are probably more important. And the gross contamination should be removed. Wound coverage with saline gauze dressings, and separate tables for debridement instruments and for skeletal stabilization. Tourniquet, it's better to keep it in position but not to inflate. And debridement principles, again the superficial ones, to extend the wound, longitudinal incisions, remove all the necrotic tissue, not to detach skin from the subcutaneous tissue, and both the non-viable and marginally viable fascia is excised, and prophylactic fasciotomy if it is required. And similarly, when we debride the soft tissue, deep soft tissues, and it has to be a dynamic approach, and when in doubt of viability, debridement is safest. And the same again for the bones. Small pieces of bones are devoid of soft tissues are debrided, removed. Large fragments are retained for skeletal stabilization and removed subsequently. Articular fragments, wherever possible, can be better to retain them. And irrigation and wound lavage, ideal volume about 6 to 12 liters of normal saline. And skeletal stabilization associated following the debridement. The benefits are it minimizes the motion at the fracture site. There is a vascular insufficiency is reduced. There is decreased pain, and the patient can be mobilized. And wound closures in a
Can I
compound
just
setting.
interrupt for a second?
Yeah.
You're already 5 minutes over time. Could you please conclude?
Yeah. And after the initial debridement, then we have to go for your CT scans and during the wait period, which guides for the fracture fragments, and plan the surgery. And the second stage of treatment is the definitive surgery performed at a point when soft tissues have recovered sufficiently to limit the likelihood of complications. So this is a picture which shows reasonably good results. Complications my subsequent speaker is going to talk on. So no one surgical treatment has demonstrated superiority over the others. However, it is recommended to use a two-phase protocol for the management of the soft tissues. So here there is not much of difference between an open or a closed fracture. This algorithm, where when it is an open fracture, you go for a debridement, and if possible, wherever possible, there is a direct closure of skin, or else we can and a vacuum assisted closure. And when not possible, we use for soft tissue flaps, and then we go for the temporary fixation with external fixators, wait up to 7 to 21 days, and then we can go for the definitive treatment. When the skin lesions permit, are not very good, and the age is not in our favor, when there is a complex fracture combination, if there is associated talus fracture, better to go for LU fusion or an external fixation alone with the associated procedures like open reduction, internal fixation, and arthroscopy. And when the skin condition is good, then we can go for open reduction and internal fixation. Thank you.
Thank you very much.
Thank you, Dr. Samarjeet. Our next speaker is Dr. Satyaranjan. Sir, please be stick to your time.
Thank you, Chairman Sir, for the opportunity. Respected colleagues, more or less my previous speakers, they have already discussed most of the part of parent fractures. I will be basically summarizing things. Now we have gone through the classification part. I'll leave it. Now the definition for us, the orthopedicians, that the fracture definition is a soft tissue injury complicated by the break of bone. That is interesting. We will see how it is so significant in pilon fractures. The soft tissue injury may present like this. In this scenario, I don't think anybody will be bothered about the fracture. It can get worse. The threat is the soft tissues. The deeper the damage, the darker is the color in the blisters. It can get worse even. So quickly we have to get the clinical information, what is the age of the patient, comorbid conditions like diabetes, osteoporosis, modes of injuries, high energy or low energy, duration, whether it is polytrauma, swelling, fracture blisters, wound type, contamination. We have to get through these informations during our history taking, then grade the fractures. We know how to grade the fractures and the compound fractures. Important skeletal determinants we must concentrate on is fibular fracture, which occurs around 85% of cases of pilon fracture, metaphyseal comminution, articular comminution, diphyseal extension of fractures, they make it more complicated. Syndesmotic injury and fracture of the talus, of course, osteoporosis. Apart from the AP and lateral radiographs, Motis view, we must go for computed tomography scan, as my previous speakers have told. This gives us the final information regarding the number of fragments, the size of the fragments, and their orientation. Different surgical options, they have been discussed: open reduction, internal fixation, minimal internal fixation with cast conventional fixator, ring fixator, hybrid fixators, and so on. The modern special frame fixators and bioabsorbable screws also have been described, but none of the above method has been proven to be foolproof. Primary arthrodesis, is it an option? I think only in one condition. It has been described in literature. Only in open fractures with extensive comminution and associated talar injury. That is the only indication for primary arthrodesis. Let us be clear about it. Conservative, not advisable in most cases, only may be considered in undisplaced stable fractures and medically unfit patients. The philosophy to go about pylon fractures, as Mars et al. Described, with all this uncertainty, it is important to choose a primary treatment which is less likely to cause complications. So the goal of treatment is restoring the anatomical joint surface, restoring mechanical alignment, maintaining joint stability, achieving fracture union, regaining function and movement, and most importantly, avoiding complications that I am going to talk about. These are the feared complications we come across: skin necrosis, wound breakdown, post-op infection, exposed implant, malunion, joint stiffness, osteomyelitis, so on. What are the poor prognostic indicators that should warn us? Articular comminution, severe articular comminution that we see in AO type C3 fractures or Rudy type 3 fractures, they are risky fractures. Talar fractures, they are dangerous for treatment of these things. Severe soft tissue injury, poor articular reduction. If the reduction is, a displacement is more than 2 mm in articular surface, it can cause trouble. Unstable fixation, post-op infection, and medical conditions. But the literature says, this comes in a recent edition of Campbell, DeCoster et al. They have decided that no correlation between severity of injury and fracture reduction with clinical outcome and ankle screws. This has come in Campbell. Interesting. Another paper by Williams et al. The severity of injury and fracture reduction, they correlated well with radiographic arthrosis, but not with clinical ankle scores and return to work. This is in Campbell. But interestingly, socioeconomic status like higher education, they showed correlation with better functional outcome and return to work. 2 or more comorbidities like diabetes mellitus with osteoporosis or cardiac problems, 2 or more comorbidities associated with poorer prognosis. Neglected cases, poor prognosis. External fixation methods, they show more restriction of motion and worse pain scores. But we must understand that traditionally we have been using external fixation in only severe cases and compound kind of cases. So probably this correlation doesn't work. But the most important point that everybody has discussed here, skin and soft tissues. We must be ready with salvage options like plastic surgery and flaps. What method to choose? What implant to choose? Virtually all methods and all implants have their own share of complications. The evidence is Rudy Algor, they revolutionized the open reduction techniques and they had excellent results. But in their series, most of them were low energy fractures due to skiing injuries. Then Ovadia and Bills, they created 145 fractures, suggested that open reduction and rigid internal fixation is the best method. But Watson, he gave some other information, treated 107 patients, and out of them 36 were open reductions, and he decided that the ORIF group, there is more number of unplanned secondary surgeries, that means more morbidity. Then Tinney and Weiss, treated with open reduction, around 60 pylon fractures, they had 50% bad major complications in their fractures, mostly related to fracture pattern. Then came the delayed surgery group. Sirkin, they did 2 stages surgery. They propagated 2 stages surgery, 52 cases. They had only 10.5% of deep infection rate. Then came Peterson and Cole. They 21 type C fractures. They delayed it for 3 weeks, and they had 0% infection. And Chen et al. 128 fractures. They treated it regularly after 2 weeks of calcaneal traction. They had 5.5% of deep infection. This was our study with Professor S.K. Kapoor. We treated 17 high energy pylon fractures with Ilizarov, irrespective of the duration of injury and irrespective of the fracture type. We used Ilizarov method, and our infection rate was 7%, 7 had no infection, pin track infection in 10 patients, they were curable just by dressing. Deep infection, none. So the evidence, we had poor results in only 3 cases out of 17 patients treated by only Ilizarov, classical Ilizarov technique ankle spanning fixators. So open reduction, where it is recommended? If it is low energy trauma, minimal soft tissue damage within the first 12 to 24 hours of injury. Beyond that, it is not recommended. But the classical ORIF, they had large exposures, which is again not very advisable. Better is MIPO, small incisions and minimal tissue dissection, minimal devascularization of bones, less wound complications. Stage procedure, as Sirkin has showed, stage procedures are mostly applicable in high energy trauma, delayed presentation, gross swelling, presence of blisters. Our speakers have already told about wrinkling of skin. Once you see this, this thing is ready for your final fixation, that is MIPO. The surgical precaution that we can take small incision that like in MIPO, no dissection of the subcutaneous plane, a minimum 7 centimeter skin bridge between 2 incisions, lateral and medial. Anatomical reduction of articular surface, metaphyseal reduction need not be perfect. Screws at fracture site, not necessary. We have to span the fracture site, we have to bridge the fracture site. Plate length, it should be more than 3 times the fractured segment. Plating techniques, major fragments have to be fixed with minimal internal fixation, and CT scan is must before that. The better plates are thin metaphyseal plates or LCPs with multi-directional screw options. They are preferred, minimum the low profile plates. Plating techniques, fibula must be plated first. This gives us the length and alignment. Then finally, there is MIPO plating of the tibia should be done. And as you can see, the fracture site has been spanned completely. With minimal internal fixation, with external fixation, that is another method that is popularized. In gross soft tissue cases, we can simply put few screws and then add an fixator. Hybrid external fixator came for this kind of grossly comminuted kind of fractures, combination of ring and conventional fixator. Ilizarov ring fixator, this uses the principle of ligamento-taxis across the ankle joint with a calcaneal ring, and after the reduction we can put a dummy ring in between to hold the fragments. After 3 weeks we remove the calcaneal ring and start ankle mobilization. The advantage is minimal invasive, no additional soft tissue trauma, strong assembly, allows early weight bearing, early mobilization, and it can be used on any amount of soft tissue compromise. Drawbacks, pin tract infection and pin tract pain may interfere with flap procedures, but sometimes uncomfortable for the patient and socially also less comfortable. It can be used in neglected cases. Delayed presentation doesn't affect its utility. No incidence of deep infection and osteomyelitis in Ilizarov technique. This fixator also can be used additional minimal internal fixations. So the take home message is primary plating is only indicated within the first 24 hours of trauma without significant soft tissue damage. Beyond 24 hours, surgery should be delayed for at least 1 to 2 weeks to be safe. Traction or temporary external fixation is a must during this delay. Don't just leave the limb like that. In case of doubt, do not hesitate to operate in 2 stages. 2 stages is better than having complication. Low profile contoured plates must be preferred over conventional plates, and biological plating, this is the recent recommendation. External fixation methods, with or without minimal internal fixation, they significantly lower soft tissue complications, of course, although they may not achieve accurate radiological reduction and are often associated with radiological degenerative changes. But I have told before, not necessarily that radiological changes can lead to bad function. However, weight bearing may have to be delayed. It may be cumbersome for the patient also. Finally, ligamento-taxis with joint spanning Ilizarov fixator is an excellent method for high energy fractures, very strong, stable, almost completely eliminates deep infection and wound breakdown. A definitive method which can be used as a single procedure. It is cumbersome, socially unacceptable, but pin track infection, and also technically demanding, but it has given us very good results. So the message is, whatever we are comfortable with, we can use the method, but we have to follow the principles. With following the principles, both the plating methods, the 2-stage procedures, as well as the external fixation procedures, they have done well for these complicated cases. Thank you.
Thank you very much.
Thank you, Dr. Satyaranjan.
Thank you.
Our last speaker is Dr. M.M. Ray. He will speak on type C pylon fractures.
Chairperson and audience. But previous speakers have already covered all the areas. Only few things are left or nothing. I will just repeat almost. You know this pylon fracture, pylon type C fracture is a high explosion fracture. The distal area when there is axial when it is loaded, and the impact area you can see here. And we are concerned in the here in only the type C. But one thing is that you see it in type the fracture lines, pure pylon fracture. But the fracture C we call it when the fracture lines it passes through the fracture line pass through the weight bearing articular surface. That is a very important thing, because in rotational fractures also in ankle it does not touch the go through the articular surface as in medial malleolar fracture. That is also distal tibial fracture, but that is a rotational fracture. But it's axially loaded and the fracture line goes through that. This is the difference. Here you see if we classify it, as you can see, the articular surface in type C, it's a minimal, almost little bit comminution, and it is almost multiple fragments. And you cannot judge it how many fragments are there unless and until you do this CT. It is one more thing, that's the plaster blisters. Fracture blister, why it happens, already told to you what this mechanism. Only this clear fluid or the blood stained fluid. Blood fluid color fluid means it is a deeper tissue injury, that is very important, and superficial, like in clear fluid blister, that means it is superficial. You know this fracture, several fractures are concerned for this fracture pattern, amount of force, direction of the force, and position of the foot at the time of impact. Already you have been told. There are some unusual fracture patterns and where both the mechanism works. That is the rotational force and axial loading. Here you see that's posterior malleolus gun with a little bit subluxation, and here also that there is some distal, proximal extension, diaphyseal extension of the fracture line. Issues are here the it is a basically intra-articular fracture, fracture pattern, how many fragments are there, degree of comminution, soft tissue damage, and proximal extension of the fracture. So evaluation already it is done, but thing is that whether it is a life-threatening injuries are there, that to be excluded first, and then you ask for this, go through this thing, vascularity, soft tissue, signs of compartment syndrome. It is basically when there is a extension, diaphyseal extension of the fracture, and the blisters, open or not, if present or not, that to be evaluated first. Type 2, 1, 2, 3, I am not going in details, as you can understand, and here is also, and if the CT will tell you, nothing new. If you go to the history of the injury, you will see that since 1911, who has termed it as coined it as a pylon fracture, you will see there was no operative treatment, conservative treatment, and the researchers found a lot of problems here, Mallunan and others, degenerative changes. Later in 70s, Algar and Rudy, they were in favor of ORIF, but they had a lot of complications as well, which was studied in 80s and after that, and it was also found if we operate between 3 and 5 days, the time of peak swelling, the complications are much more. In early 91, the swing was, there was a change, external fixation with limited ORIF, and late 90s, then once again it was popularized, that is the staged protocol with temporary external fixation and delayed ORIF. Radiographic, already it has been mentioned what are the views to be done, including the mortise view and full length and all. I am not going to repeat it. CT scan, how it is helpful, that has also been mentioned, and already been mentioned by previous speakers. But most important thing is that previous speaker has already said span and scan. That is very, very important. That is, you span it, you see, and after that you go for the CT. Then you will have the exact position of the fragments before you go for the surgery. Here it is. And the treatment options, you know that the various treatment options are there. There is the plaster immobilization, traction, lag screw fixation, or if with plates, and external fixation with or without limited internal fixation. In C1 fracture, jolly well you can go for the conservative treatment, and you can treat it by a plaster if there's no. Then patient can have a good range of movement. Here is one fracture. This is basically, I told you, I've shown it earlier. This is a posterior malleolar fracture and the fibular component, which can be treated jolly well by lateral approach. You go for the tibial, lateral fibular fixation, and from that lateral approach, you can fix the posterior malleolar part with the lag screw, and that's all. You need not have any plate fixation. Prerequisites, important to define, and clearly the amount of soft tissue injury. Closed soft tissue injuries can be quite severe and can adversely affect the functional outcome, especially if it is unrecognized. That is very, very important. So definitive reconstruction through open approaches should be delayed until soft tissue swelling has decreased. That is an important issue, and you go for the always wrinkle signs after a spanning. Wrinkle signs appear at not, or the rise treatment. Our ultimate treatment goal has already been mentioned, that is restoring an anatomical articular surface, restoring the mechanical alignment, maintaining the joint stability, achieving fracture union, and regaining functional and pain-free weight bearing and motion of ankle. That is very, very important. So issues here are the components to be understood, several components of the fracture, both in tibia, distal tibia, and the fibula. And tibial articular surface, this is the posterolateral and anterolateral fragment, and medial malleolar fragment, the position that to be assessed just before going for surgery. And careful analysis of the injury of the films in CT review to be reviewed, and characteristics of the fibula fracture. Fibula is a very, very important one that to be addressed. Particularly the compression fractures of the fibula are associated with the valgus injury force. And so all implants or whatever you do, you approach through the lateral way, and it should be laterally based implant is needed to resist this valgus pattern and to prevent later displacement. Here is in one, so nothing, there's no reason to neglect this fibula, and the result is you see the malignant. And this sort of fractures, you can see jolly LP can be treated just by need not going for the spanning and all. It is a soft tissue injury is less, and you can go for this anatomical plate. And this is another fracture, can be treated like this. Stage treatment protocol is very, very important for particularly the C2 and C3 fractures. X-fix followed by the delayed ORIF. And it has been recommended by many researchers, and delta frame is applied first, spanning, and then you apply 2 pins in the tibia and distally in the calcaneum and talus, and then you go assess the soft tissues when single sign appears, when the patient is ready for surgery, and go for the definitive ORIF. Peterson and Cole, they described the immediate fibular fixation that has also been described mentioned by previous speakers, and placement of a medial spanning external fixator, followed at an average of 24 days later by removal of the fixator and ORIF. So delayed ORIF, and primarily there is a fibular plating. But question is here once again, it is not also without any complications. That might be a problem initially, large soft tissue dissection and bone stripping while you are going for the fibular plating initially. It is like that, is a procedure like this, and later it can be done, the tibial component can be managed later on. Here is such after plating. This is another, when in open fracture, initially spanning and later by component. So operative principles already mentioned that in nutshell it can be said that is that soft tissues to be protected first, and most important thing is the full thickness skin flaps. That is very, very important.
Sir, you have 1 more minute on.
Okay, thank you, sir. I'm almost finished. This has been. So advantage of this thing, stable fixations, the increasing mechanical stability, assisting reduction of the anterolateral fragment, and restoring the length and alignment of the tibia. And tibia, this is also very important, that is the low profile plate should be used. That is one point here. And about Elijah already mentioned by my previous speaker, this is very, very useful, I think, but for those who practices Elijah regularly. Otherwise not for the general persons who does not do it. But here you see this olive wire, the olive that can reduce the fracture and that can stabilize it, and the pin here it is. You can see after introduction of this olive wire, and it can stable the fracture site, it can reduce it, and construction is like this. So complications as already mentioned, of course, is there in any surgery. Here is also, and primary arthrodesis has also been advocated, but rarely it is done, I think so. So, and secondary arthrodesis later on, if when complications are there and when the ankle is very much painful and not relieved by any other method. So, take home message is the soft tissue damage to assess first initially, later on also, and lastly before you go for surgery. Wrinkle signs to observe. Delineate the fracture fragments at any stage. X-fix ankle spanning is the initial measure. A soft tissue healing to assess again, and staged protocol in C2 and C3, and minimal invasive surgery. Thank you very much.
This is the last session of the today. Now we can proceed for the cricket match.
Yeah. Everybody is in there.
Thanks for all the delegates for staying till now. It's pretty impressive. Thank you very much.
Thank you, sir.
C2, C3, which incision you give for reduction of the LM?
Which incision? It depends on whether the fragment is the medial or the lateral. Or
It's the middle one, no? The weight-bearing part. How you reduce that?
yeah, it is a very difficult question, but only thing is this, part operatives image.
Not image.